Hi, everyone. Oh, hi, Lara. Hi, everyone. I'd like to introduce myself. I'm Andrea Stone. You can call me Andy. I'm the director of the Mood and Anxiety program in Chicago.
And I'm Jenni Schaefer. Thank you guys for joining us. I'm actually going to be giving the patient perspective today. I'm an author and I'm a national recovery advocate with ERC, Eating Recovery Center, and Insight Behavioral Health Center.
Hi, everybody. My name is Lara Effland, and I am the Managing Director of Clinical Operations of Eating Recovery Center, and I'm in Washington.
Okay. Let's get started. If you all know how to raise your hand, we're interested if anybody has already heard the first few webinars. We're hoping you have. We're going to do a summary of what we've already presented, and then we're going to move into addressing barriers to treatment and finding recovery with PTSD. So I'm going to start and tell you even a quicker story of the story I've already told on the slide of these three amazing women you see. I'm going to start with Marsha Linehan. As most of us know, she's the founder of DBT. She spent her life's work developing a treatment program to treat chronically suicidal patients, most of whom have presented and present with the borderline personality disorder. It's widely known DBT is one of the few empirically supported therapies for clients who present with multiple problems. And while DBT was first created by Marsha to treat suicidality and BPD, it is a very strong research base and targets a wide range of problems, many of which overlap with PTSD and most conceptualizations of complex PTSD. Melanie Harned, who you see in the bottom, she was a student fellow of Marsha's. She spent 11 years of her life. Is it 10 or 11, Lara? It's between those numbers.
11, yeah.
Thank you. Developing the DBT-PE protocol, which is the protocol that we are going to be that we've been talking about. She saw a need for a new standard of care to treat PTSD in the population that they have worked with, which is borderline personality, suicidality, high risk, comorbidities. Melanie was not satisfied with how the DBT manual addressed PTSD in stage 2 DBT. The next slide is just a review of the stages of DBT, and I'm going to get to that in 1 second, but I just wanted to remind you that the first part of our series really focused on DBT and showed how DBT overall informs treatment of trauma and PTSD in stage 1 and stage 2. While the DBT manual recommends exposures as the primary treatment for PTSD, it does not describe how or under what circumstances to implement PTSD treatment. So this is why Melanie came up with the idea to integrate an evidence-based PTSD treatment. After all, she was a researcher, so she wanted to use an evidence-based protocol within DBT to treat PTSD in this high-risk population. And so you see Edna Foa. Edna Foa is the founder of prolonged exposure therapy, and we'll again review that in a little bit, in a few slides, for permission to use prolonged exposure and integrate it within DBT. And fortunately for all of us, she said yes. And that's the story I wanted to share on this slide. And I'm just going to pass it on to just review the DBT stages of change. And as we see in stage 1, this is where Marsha Linehan spent most of her work, and the manual focused mostly on stabilization. As you can see in stage 2, emotional experiencing, this is where Marsha said, this is where post-traumatic stress needs to be targeted and worked on. And the DBT-PE protocol will guide us and informs us how to do that. Patients can only enter stage 2 after they have the skills to experience intense emotions and to hide distress without escaping or avoiding. Okay, that is where I want to go with this slide. Now I'm going to give it to Jenni.
Hey, thank you so much, Andy. And thanks again to all you guys for joining and for all that you do. I truly would not be here today doing this webinar as someone who is in recovery and doing very well from PTSD if it weren't for people like you. So thank you. So I'm going to be sharing a lot of my story today, but in little chunks. And if you've already heard our talk, you've heard my story a few times. So I'm actually going to speed this up on this slide and really just focus today on what's really key for our specific webinar today. And so if you look at the case study slide, and that's me, I'm your case study for tonight, what's really important to notice is the beginning of my life, there was a lot of complexity, right? And there's stuff that you don't even see on there. So at 4 years old, I had super, super high anxiety, but also along with that came highly sensitive. I was very, very sensitive, very perfectionistic. I also struggled with obsessive compulsive disorder as a child. So if you guys treat eating disorders, you know that some of these traits can make it likely for someone to, or more vulnerable to develop an eating disorder. So many of you are probably not surprised to see the ED on the slide there. ED stands for eating disorder. And that in my life was about age 22 when I was diagnosed with full-blown anorexia nervosa. Of course, and that was a slow time coming. I struggled with eating disorder thoughts probably from the age of 4 until I finally was diagnosed and got help at age 22. And what's interesting and unique about my story than maybe some of your patients who have comorbid eating disorder and PTSD or trauma is that my trauma actually happened after I'd already been in 5 years of really good eating disorder treatment. So imagine some of your patients who maybe you see now, who they're 5 years into eating disorder treatment, doing pretty well, maybe not fully recovered. That was the case for me. Well, then I experienced rape at the hands of someone I trusted. It was a boyfriend at the time. And as you might expect, I started developing post-traumatic stress disorder symptoms. And as you might expect, my eating disorder behaviors started flaring up again. So I had them under somewhat of control because I'd been in treatment for about 5 years. But the thing with PTSD is that the symptoms were so devastating, even in the beginning, just the symptoms of exaggerated startle response that was starting. I struggled a lot with dissociation. I struggled a lot with hypervigilance. These were so devastating, even in the very beginning, that I started numbing out by binging and purging, and we see that a lot. You guys can read the research there on your slide, and if you're on the phone and you can't see the slide, I see some of you guys are. About 37 to 45% of adults with bulimia and 22 to 26% of those with binge eating disorder have lifetime prevalence of PTSD. So I fit in that case. Now, the key here was that I did recover from my eating disorder. I had had 5 years of really good treatment. So I got better, but looking back, I can see a very interesting point, and that was that my PTSD symptoms started decreasing. The hypervigilance started going down. The startle got less. But why was that happening? Well, that was happening because I avoided. Now, gratefully, I did break up with that boyfriend, and I needed to do that. But what I did not need to do was avoid dating, avoid intimacy. And as I avoided, as many of you guys know, if you avoid what you're afraid of, in the moment, it can decrease the stress. So, yeah, my PTSD symptoms kind of dissipated for a time, and I was able to move into full eating disorder recovery. But then later on in my life, a life event that usually is happy and something very joyous that people look forward to happened that triggered full-blown PTSD. And you're probably not surprised to know that that was a wedding and an engagement and a honeymoon and a marriage. So when you see full PTSD on this slide, what that was in my life was intimacy, was finally becoming attached to someone. And so PTSD flared up at a full-blown level, way, way more intense than it ever had been before. And so the question for me would then become, A, what treatment works? How do I get better from this? And B, how can I get better from this and not relapse back into the eating disorder that devastated my life for nearly 20 years? So it's a complex, my case was complex considering all of those factors. And as we speak today, I'm going to talk about how I was able to get better and how I was able to do that. So I want to pass it back to you, Andy, with the DSM-5 criteria slide.
Great. Thank you, Jenny, for sharing your story with us and for sharing and being so brave and vulnerable to share that throughout this presentation. Not going to spend too much time on this slide just because we have so much to talk about. And our assumption is most of you are familiar. Most of you are familiar with the DSM-5 criteria for PTSD. And just as a reminder, it's no longer an anxiety disorder, but falls in the category of trauma and stressor-related disorder. There are dissociative subtypes now with PTSD, and what is one new feature is that learning about a traumatic event happening to a close family member or friend serves as a trauma according to DSM-5 criteria as a traumatic event. Jenni or Lara, is there anything else you would add to this slide before I move on?
I think that's great.
Yeah, I mean, it might be something to point out is with DSM-5, many of you might know that dissociation was added as a subtype of PTSD. Is that right, Lara? Yeah. Yeah.
Yeah.
Yeah, there's depersonalization subtype and derealization.
That was something I struggled a lot with, and so for me as a patient, it actually became key for me to kind of learn what those things, what those meant, you know, depersonalization, derealization. But anyway, so.
Would you be willing to give a quick example for us?
Well, sure, Andy. Yeah, so, you know, my PTSD, I mentioned it was, you know, when I got married, but what did it look like? It had dissociation, it had suicidal ideation, it had extreme rage. And for me, the rage piece was often tied to this depersonalization. I remember yelling at my husband, just yelling at this extreme rage. And it was the strangest experience, and it happened many times, but I was like above my body to the right, looking down at myself in his office, yelling at him. And so I was really not in my body, watching myself, and that was something I'd never experienced before and was very scary. And then with derealization, I remember walking around the world in my PTSD, and it felt like I was in like this, like a fishbowl almost, where I was kind of watching the world, but I wasn't really a part of it. It was really hard to explain, but that might be a better sense. But it's important I think, for me to show that, you know, patients don't know what that is. We are very confused and we don't know a name for it. And for me, it always helped to have a name. So knowing, oh, that's dissociation, that was like really helpful. Just like when I found out PTSD had a name, which is a whole other story, but it took, you know, about 10 years to get that diagnosis. So for me, labeling became really important. Not to label, but to get help, to get a name, to know where to go to get help.
Thank you. Well, thank you, Jenni. Okay, I'm going to switch the slide over to common complex comorbidities. This research statistic is staggering to us. 66 of individuals with PTSD have 2 or more comorbid disorders, including substance abuse and personality disorders. And of this group, 30% attempt suicide. As you can see, suicidal behavior, non-suicidal self-injury, severe dissociation. And the last point here is there's a high comorbidity with borderline personality disorder and PTSD. 30 to 50% of clients with borderline personality disorder also meet criteria for PTSD. So we just thought this was an important slide just to review and remember it's why it can be so very difficult to know where to start when we're treating a patient that presents with PTSD and comorbidities. Moving right along, this was again, this is a review of just slides we talked about from the first webinar, there are myths that exist about treating high-risk patients with PTSD and comorbidities. You know, and I admit, I was one of these therapists that initially, before I even understood PTSD, felt that patients with PTSD and, you know, suicidality, they were not safe enough to be treated. That working on their PTSD would increase their self-injury or that they would lose behavioral control. And a very interesting point that these patients don't want to treat their PTSD because they can't tolerate the distress. And the research actually shows that if patients are presented with options to treat PTSD, they're overwhelmingly going to say, yes, I want this treatment. So it's a reminder for all of us that it's important to present to our patients options for treatment as we work with them. And
I'll add,
yes,
go
ahead.
Did you want me to talk yet?
Yes.
So,
no, it's your turn.
So if you guys can see the slides, you guys can see that book on the slide, and that's Dr. Edna Foa's and Dr. Barbara Rothbaum's and Dr. Elizabeth Hemry's book on. It's the workbook for patients for prolonged exposure. So if you're interested in getting into prolonged exposure and learning it, you would have the manual as a clinician, and then this is the workbook that you would give your patients or your patients would get. And I actually found out, once I realized I had PTSD, I found out about prolonged exposure therapy because I'm lucky enough to have friends that work at Harvard Medical School and are researchers in PTSD. So I'm pretty lucky. When I called one of my friends and said, hey, what do I do for treatment, she said right away, you should check out prolonged exposure, and sent me to this workbook. I bought this workbook immediately, and I was so excited about it. I was begging to do treatment. I desperately wanted to get treatment for PTSD. And people often say, I've heard it at conferences and things, that, well, maybe prolonged exposure comes across as being barbaric. I've actually heard people say it seems kind of barbaric. You're making people face their fears. But what I know from my personal experience is PE, treating my PTSD was not barbaric. The PTSD itself was barbaric. You know, and treatment is scary, yes, but staying the same was scarier. And so I think a key for me here was just simply, I really wanted to do this treatment. For me, it was what I needed to get better. It relieved the symptoms. And the key, too, is that I did not relapse into my eating disorder. So even though there was that comorbidity that could have possibly flared up, it did not. So that's a key to share, too. Never once did I relapse. And I was doing a very intense therapy. So I'll pass it back
Jenni,
to you, Andy.
Thank you. You would agree that it's PTSD is hell, not the treatment.
Absolutely, definitely. And PTSD itself is it's hard to explain, but I call it the invisible monster. It's absolute torture. It's agony, you might say. And so, yeah, the treatment itself, I mean, I was begging to do the treatment because I wanted to do anything to get out of that pain. And, yeah, the treatment was hard. There were definitely hard parts, and you guys will hear all about it tonight. It's how I got better. I needed to go through those parts to get better. So, yeah, thanks for asking. So and I think this is important just to reassure you guys that, you know, it can seem scary, I'm sure, when you're encouraging your clients. We're going to get into some exposure examples later, and I'm sure it was scary for my treatment team to have me jump into those, but I'm so glad they did, and that they probably sat with some of their own fear about it and let me do it, because that's how I got better.
All right, thanks, Jenni. I'm going to pass it on to Lara.
Thank you. And, you know, one of the things that I really appreciate, Jenni, you just even mentioning a little bit more about, you know, the misconceptions and preconceptions that people can have about doing exposure therapy when it comes to trauma. And, you know, that I still think even today, after many, many years, you know, decades of research and what exposure therapy has, and the evidence around exposure therapy and how it has advanced our treatment for PTSD, you know, that people still hold on to that myth that exposure therapy causes a patient to regress and to actually exacerbate their issues versus treat and cause healing for the patient. And so I think that's why we credit and really wanted to talk about Melanie Harned's work, is because she's also trying to dispel that myth and really try to give way to the opportunity of the DBT protocol. So, which leads me to where did Melanie Harned even come up with this idea? And it really was, being under the fellow of Marsha Linehan. She was reading in Marsha Linehan's book back at the, Cognitive Therapy for Borderline Personality Disorder, is that Marsha even believed that in the 1990s that the resulting havoc in the patient's life and the suicide risk are such that the treatment of post-traumatic stress disorder, PTSD, has to be very carefully timed. So in the DBT treatment manual, they were encouraging the use of exposure-based treatments for PTSD. However, it did not describe how or when and under what circumstances to implement this exposure therapy. And so when I started to learn prolonged exposure therapy, not including the DBT protocol, I also had that same thought of, well, what do we do with these co-occurring high-risk behaviors? How do we support someone who's starting to go closer and get closer to their trauma memories and are having these strong reactions of PTSD and around their PTSD, and it's hard for them to regulate in the sessions. And some of my patients would begin to increase avoidance and numbing of their emotions, and others started to intensify their behaviors, such as non-suicidal self-injury, and others would stay the course and they managed well and they didn't necessarily have high urges to use other behaviors. And so it was an interesting experience as a therapist doing prolonged exposure therapy and asking myself, I feel like we need more. We need more of a protocol for our patients as well. And so when I came across this DBT-PE protocol, it really answered a lot of my questions around that. So what is, prolonged exposure therapy? Well, it is protocol driven, which means as therapists, we get to look back and look and assess and see what is the process in which we treat our patients and when and how. So it is protocol, evidence-based, written out for us. Now, this is what I like to call the science, and then the DBT is the art form, or the treatment of trauma is the art form. The science meets the art. We need this protocol as a backbone, as, if you will, if we were to build a house for the support and the healing of trauma, we would need these as the foundation, the support structure, the bones of what we're really asking our patients to work on. And we would also be doing emotional processing of the PTSD, which is essentially confronting the thoughts, feelings, and physical sensations that arise when remembering one's trauma. And we want to help them slowly change these harmful core beliefs and erroneous cognitions related to their trauma to really help show the mind and the self that facing the memory is not as painful as the brain perceives. And instead, it was, the captured memory is painful, but facing it is actually healing. And we really will do a lot of this through orientation. In order for us to help our patients, we need to have their willingness, their buy-in into the fact that there is a treatment out there that can help them and that this treatment is effective and there is evidence around that it has a high likelihood of positive outcome. And so this education on common reactions to trauma and avoidant behavior's role in PTSD and how it actually prolongs PTSD, and going over the different types of exposures that we'll do and the different, and to generalize it and to really titrate it, doing different objects and places that trigger traumatic responses, and then doing the repeated prolonged imaginal exposures to the retelling of the trauma memories. So to really kind of remind ourselves that the exclusionary criteria for PE are all of the borderline personality disorder symptoms that we tend to see, or the high-risk behaviors that we tend to see with our patients. And for prolonged exposure therapy and all the research and evidence that they showed of the effectiveness and the efficacy around the treatment, we
I did that. Sorry.
Oh, that's okay. It was actually excluding these particular individuals. And so Melanie had a question of, okay, so is prolonged exposure therapy actually evidence-based and supportive of this population? And so she really felt that it was important to continue to clear that up and get more information around it. Now what she came to find, and the research shows time and time again, through a comparison study, is that no, it does not prolonged exposure does not exacerbate these symptoms. And that dialectical behavior therapy also can be a great support and encourager of healing and helping the patient work through the trauma and the prolonged exposure therapy protocol. So she created the DBT-PE protocol to then assist with these behaviors and high-risk behaviors. So there are 3 stages of this protocol. The first one is going to be the most important. It is the foundation. Now the time in which you spend in stage 1 with a patient sometimes is surprising to people, which stage 1 is the DBT skills training stage. It is the stabilization of the behaviors, helping with actually regulating one's emotion. In order to really show that a patient can regulate one's emotion, they need to go through varying levels of intensity and showing that they can tolerate higher levels of intensity. And so the DBT skills training can sometimes take 9 months to get through before you move on to stage 2 of the protocol. And the purpose of that is to really recognize that the basics are going to help you move forward and be successful in that treatment. And that includes the assessment of the current emotional ability and regulation ability, the orientation to PTSD, the trauma response, trauma treatment, and then the psychoeducation around prolonged exposure therapy and PTSD education and the responses that the body and the brain have. Stage 2, once the patient is ready for that, and that is assessed over time by the patient and the therapist, that they have shown and have proven to use skills effectively. We'll go into the DBT-PE protocol of the trauma interview and then designing and developing in vivo and imaginal exposures as you would in any other exposure therapy protocol. Now if you are not familiar with exposure therapy, I highly recommend going deeper into this treatment. Again, this is just an introduction to the DBT-PE protocol. This is not a training around it. And so in order to really know this stage 2, you do need prolonged exposure therapy training and exposure therapy training as well. Stage 3 is then the aftercare of the treatment. So building a life worth living, giving the tools to the patient to become their own exposure therapist, to help them change these life interfering behaviors, change symptoms, so that can be continuing to support eating disorder recovery, substance abuse, those co-occurring disorders along with the trauma, and aftercare, helping them really build long-term goals, helping them achieve things outside of their PTSD. So just as just a little bit of a picture to show you a pretty standard treatment timeline for the DBT-PE protocol. Stage 1 is skills training, stage 2 is DBT-PE, and then stage 3 is building a life worth living. So the stage 1, like I said, it can last as long as needed. There's a lot of people who are in DBT training for a year in order to really feel that they are equipped and able to move forward. That's okay. There's nothing wrong with that. Then stage 2 DBT-PE, on average the sessions can be between 6 and 12 sessions to start to show significant changes in PTSD. The prolonged exposure therapy is traditionally a 90-minute session 1 time per week. The DBT-PE is traditionally 2 60-minute sessions per week. One is a prolonged exposure therapy focused. It is just solely focusing on the trauma, and then the other is a DBT-focused session where you're just focusing on the skill set around using DBT to then support any of the reactions or responses or emotions that are related to the experience in the trauma treatment. Now, if you do not have more than, you do not have the opportunity, or you do have the opportunity to do groups for DBT, you could do one 60-minute PE session per week and then do a DBT group session where you are getting DBT skills training in a group setting. That also suffices. Something that I think is really important for us just to review real quickly are the common reactions to trauma, the under-controlled and over-controlled, because these will actually be things that come up and that you'll see time and time again in the barriers to the advancement in the treatment. And the reason being is because when you start to increase the intensity in facing these memories and going back to things, the body is going to respond the way that it knows how, which is to protect. Maybe some fight, flight, or freeze, some avoidance behavior is going to pop up, or impulsive behavior, a want to control, a want to find other ways to numb or find other options or connections. So really to notice behavior regulation, interpersonal connection, and emotional experiencing, and whether or not they are on the over-controlled or under-controlled spectrum. I talk about this with all my patients. We go over this as a teaching tool because a lot of times they are presenting either one or the other, or they have a mixture between the two. So the two types of exposures that we do in prolonged exposure therapy for PTSD is imaginal and vivo. Imaginal is just going to be verbally repeating the memory, so it is a retelling of the memory of the trauma. Now sometimes for those who do not have really strong memories, or there are pieces missing or large pieces missing, that is not necessarily a reason that they cannot do the treatment. However, it may be a barrier to the effectiveness of the treatment. And so that's something that you just want to be navigating together as you're going through the retelling. And you would also want to be seeking consultation around that as well. And in the imaginal, what you are is verbally retelling and describing the memory from beginning to end. And so you determine together what the story will be, where you start, and it's as specific as I was in the car, it was a Tuesday night, and it was raining. And when you retell that, you start there, I'm in the car, it's Tuesday night, and it's raining. Every single time that you retell, that is a part of the imaginal exposure. You're repeating this time and time again. You're recording it each time, and then the homework is to listen to that recording outside of the session. And you determine the length of time in which you are going to be doing the retelling. So you could be doing that memory, that retelling for 20 minutes in that session, and you record it for that full 20 minutes. Even so, when you determine the time in which you do that retelling, and you record that, even if the memory is only 5 minutes long in the retelling phase, but you've set the exposure time to be 20 minutes, then they repeat the retelling until that 20 minutes is up. They just keep doing the same story over and over and over again, and that's a part of the exposure. The in vivo exposure on the other side of that is starting to find a list of things in which they may be avoiding due to the trauma, due to the PTSD, such as crowds, such as being around new social situations, avoiding job interviews, avoiding things that cause them more distress or things that cause them too much positivity, not celebrating things and so forth. So finding things in which their PTSD has negatively affected them and has caused them to lose things or to feel overly stimulated in things, and so they avoid them. And that will also in tandem break down those fear structures that are related to their trauma. So we're doing both the retelling of the memories, and then we're also doing the real life situations in which the PTSD robs that individual of living. Very important thing to remember as well is the emotion tracking that goes on during this process of the retelling is that we want to know what are they feeling before they retell and what are they feeling during and what are they feeling after. You know, the main core emotions, the universal emotions that we touch upon in DBT, we're going to be tracking throughout the retelling. So sadness, fear, guilt, shame, disgust, anger, radical acceptance. How do they feel? Do they feel the radical acceptance 1 to 100 before the retelling and after the retelling? Also, do they feel like quitting therapy? We want to know that. What is the urge to quit therapy? What is the urge to use self-injury? What is the urge around suicide? What is the urge around substance abuse? And then we also target through the tracking, what are the preconceptions before going into the retelling? What are you afraid will happen? So some people might say that I'll pass out. Some people might say that I can't handle it. Whatever those thoughts are that come into one's mind. And then you also ask them to share between a level of 1 to 100. Now, if that actually happens, how bad would that be from 1 to 100 of intensity? And then you go back and you track after they do the retelling, did that happen? And if it did, how bad was it from 1 to 100? And that also is reality testing around what their preconceptions are and how they're perceiving and processing these emotions and these thoughts and memories, and then what the reality is when you face it. Huge component of this treatment that we don't want to lose. And it's also, a lot of this information is so useful when we start to go and see what are the barriers, how do we troubleshoot through the difficulties through this treatment, because it's trauma. You know, working through trauma is an art. There's science and there's tons of art to this. And so how do we figure out what's happening with each of our patients and what they might be struggling with? And this tracking system is going to help you figure that out. So let's get to the troubleshooting, shall we, ladies?
Do it.
Yes, we shall.
We shall. So, you know, and I think it's so, this is the thing that I really do appreciate working with Jenni and Andy is that, you know, we are talking about trauma. This is really, when we are working with our patients, it's difficult, it's overwhelming, but they always do bring some fun, which as therapists, we need to find that kind of reflection and learning and really enjoying working with one another to learn from one another. And so I really appreciate you too, and always, you know, reminding me of that. So
thank you.
It's easy for us to get hard on ourselves when we're working with trauma patients, and also when we're working with high-risk behaviors, because it's tricky, and sometimes we think that it's something that we're doing. So barriers to treatment. So Andy, you and I are going to go through these together.
Mm-hmm.
And these are, you know, we're going to be kind of breaking each one of these down through the next section of this training. And, you know, and Jenni's going to be sharing some of her own personal examples around that. But these are common barriers to treatment that we've seen in our own cases, but then also that research has shown time and time again tend to occur for those that are treating trauma. So inability to tolerate distress, high-risk behaviors, even when they are not using them before they go into the treatment, then they pop up. The urges get really intense, or they give into them, or they start to have really strong suicidal ideation that goes from passive to active. Something that's really important to recognize as a barrier is any sort of invalidating environment that could be causing more traumatic invalidation, you know, that is minimizing their trauma treatment, minimizing the, you know, how this has affected them, or the importance of working on it, or that is continuing to be abusive. Pervasive, distorted belief systems. So this is where they are you keep moving forward and you're doing the retellings and you're working on the memories, and they keep saying it's all my fault. No matter how you work on it or you try to target it and you continue to help them see or reframe it, or you're working on it in so many different creative ways in both individual or group or so forth, and they keep feeling like, but no, it was my fault. Anything you want to add to that, Andy?
No, I just think the idea of fusion comes to play. How fused are they with those thoughts, with self-blame? And yeah, agree with you. That's probably one of the most, the fused, distorted belief systems are, for me, probably one of the hardest barriers to overcome. Yeah, I think I would just want to add that to that part. And
Great
just going
point.
back up to inability to tolerate distress, this is where it's so important to, in stage 1 DBT, really making sure that they've learned the skills, they practice the skills to tolerate the higher emotional intensity that's going to come with doing trauma work. And as we'll talk about, we just may need to pause for a couple weeks so that they can, go back and practice via most likely doing exposure work to tolerate emotional distress before we go back to the protocol.
Right.
Yeah, and this is where, guys, I have to thank you for having me a part of this. This is Jenni again, if you guys don't recognize my voice. But, this is where, for me, the inability to tolerate distress, I did not have a lot of skills to tolerate distress at all. And, in fact, part of my story that I wanted to share with all of you listening today is that back when I was actually getting my PTSD treatment, Dr. Melanie Harned's DBT-PE protocol research was actually not widely available. So really I was doing PE in outpatient without DBT. And because I personally needed more safety, more stabilization, I needed distress tolerance skills. I actually could not tolerate prolonged exposure in outpatient, so I ended up going to a partial hospitalization program that actually had PE. It was focused on PE, and it had a DBT group, which was awesome. So I was getting closer to the protocol, but in this program, the DBT group, we never learned distress tolerance skills because rightfully so, clinicians were worried that we would use some of these distress tolerance skills in exposures where we were not supposed to be using skills. So we didn't learn distress tolerance skills. So the next phase of my treatment was I ended up in the psych hospital. So talking about, I was really outside the window of tolerance and I had a lot of distress, did not know how to tolerate it. But luckily that was, like you said, Andy, I loved that, a pause. The psych hospital was a kind of a reset, a pause. And there I was able to get the safety and stabilization I needed, went back out, went back to the PE program, and I was able to complete it. So that was, but a huge barrier to my treatment was simply that we did not know about the DBT-PE protocol at the time, and that's why I love doing this talk, because it just speaks to the importance of research and dissemination, right?
Yeah, definitely. Thanks for including that, Jenni. Yeah.
So someone has a question. So question about barriers to treatment. How do you deal with those fused, distorted belief systems when clients are completely tied to these distorted beliefs? I'm worthless and cannot accept any other reality.
Great question.
Yeah.
Would anyone like to start?
I would just what comes to mind initially is to practice exposures to joy or practice exposure to self-compassion. So, where that might be, oops, my screen just went black, where that might be, we know how fused they are with their worthlessness. Let's get them to maybe view, I don't know, a really happy movie and get them in touch with the emotion of joy. And that's what we'd be working on in their in vivo exposures. That's something that came to mind thinking about this, as well as really working on acceptance commitment therapy, working on the diffusion skills, we've found really helpful. And diffusion skills are very similar to Marshall Linehan's mindfulness of emotion and mindfulness of thoughts skill, where we're practicing a non-judgmental stance toward our awareness of our thoughts and feelings. Hope that's clear. And would anyone like to add to that?
Yeah, I think that's a really creative thing to do too. Like, that reminds me of the art, of coming up with ways to support someone. And so when you said, doing an exposure around joy, which is really the opposite of what you had said, which is I'm worthless, or what the person who wrote the question about I'm worthless is, what is it that they're avoiding? Like, holding on to that belief, holding on to that thought, what is it protecting them from? And so getting down to, which I thought was really great of what you said, Andy, because it really kind of gets down to, well, if you were to no longer feel that way, what would arise? What would come forward? And maybe it is joy. And what would it feel like to feel joy? Would that actually cause more vulnerability? So one of the things that we do, so for instance, I cannot accept any other reality, is then targeting radical acceptance. After each imaginal exposure, having them generate a radical acceptance statement. And then do a brief mindfulness practice of breathing in the statement and focusing on the sensations that occur when you breathe in this statement. Starting to bring in these radical acceptance statements, or bringing in the opposite of what that core belief is, and doing mindfulness around it, and trying to bring it into the room and see what comes up. What is the barrier? What are the emotions in which that person is trying to suppress, or trying to avoid, or to numb out?
Yeah, and to go along with that, just thinking about subtle ways, even with nonverbals, doing an exposure around, typically people who are so fused with worthlessness, feel tremendous shame, and so begin to expose themselves to unjustified shame, right? Like using, telling a story to the group and making eye contact with each person. Those are, this is where, again, the art and the creativity of being an exposure therapist. I never really thought that I could be this creative doing exposure work. And it wasn't until Lara, you brought exposure work to our program, and I'm like, oh my gosh, we can be this creative. And we just have to keep practicing, and it's working with the patient, asking them, what do they think is going to help them target this distorted belief system? And really maintaining the hope and hope for them. We maintain that hope for them until they can begin to hold on to some of that as well.
Okay. Please let us know in the Q&A section if you have any follow-up questions, anything that you need from us. We're happy to help.
Yeah, we love questions.
So let's kind of move forward where common reasons for dropout. Oh, sorry, I don't think we finished actually. So avoidant behaviors, this can come up in a lot of different ways in which the patient is even being avoidant of the emotions in the retelling. And when you do a retelling, you're asking the patient to really move forward and go deeper into what do you think, what were you feeling in that moment? What was the thought process around that? What did you do? How did you feel? Where were you going? And so forth. And sometimes they almost just continue to give you the weather report. No matter how much redirection you give them, no matter how much you try to help them go further, down, deeper in, it's the weather report, right? So that's an avoidant behavior. Not even showing up is a pretty blatant avoidant behavior. Jenni, any avoidant behaviors you recall?
Oh my goodness, you guys are so smart. I'm just taking notes on everything you say. Yeah, I mean, avoidance of emotion, I think that's such a key one. And I don't know if this relates, but since you brought up shame, I'd actually love for you guys to address this too. But my therapist used to tell me, I mentioned I struggled a lot with intense rage, and my therapist would often say, well, you might be experiencing rage because you're avoiding actually the shame that you're feeling, and because rage was a more powerful emotion, and in some ways it felt, I guess, strong and almost like I controlled it, even though I completely didn't. But shame he would describe as kind of like a yucky emotion. It just feels really bad. So often we worked on how I might be avoiding shame and instead moving to anger because it kind of, feels a little bit better and stronger. Does that make sense?
Yeah.
Yeah.
It's a lot of that.
So definitely avoided. One of my best assignments was making an avoidance list. It was pretty long.
And that's interesting that you use the anger, because I remember reading in the DBT-PE protocol that one of the signs that maybe the protocol's not working is when anger and sadness increase, which it's expected to increase, but then they don't decrease.
Right.
If that makes sense.
Well, and it's not that it's not working, but that there's a barrier, that there's something that's coming up for the patient that, again, the radical acceptance is a key part of noting where we're going in this treatment. Something is not being radically accepted.
And that's not no easy task, Lara, to practice radical acceptance.
No, it is not. So therapy interfering behaviors, again, just inconsistent attendance, showing up late. It is really hard to do trauma therapy when your client is consistently late because there's so much that goes into that time that you have with them. Medication noncompliance, also very difficult to be consistent in your trauma treatment, and lack of engagement in the session. Again, more of that weather reporting or just inability to kind of continue to follow your questions or engage in what the tasks are, the homework is, and so forth.
That reminds me of, Oh, go ahead. We'll get to what I was about to say later.
Okay. Common reasons for dropout. Again, that problematic beliefs are not changing. I am bad. No one believes me. Over-engagement. So this is where you will see an overwhelm. They can even get to a dissociation, struggling to manage emotions and urges, or under-engagement, numb, apathetic, inconsistent attendance, lack of motivation. Sometimes over-engagement can mask as under-engagement. And that's more of that dissociation presentation. It's almost like a deer in headlights is in your, in that space of just not really showing or giving a lot. However, that's actually over-engaged. That dissociation is someone who is, their intensity, their experience is so high that they need to leave in their minds or in their coping. And unjustified emotions are not changing. That shame, that fear, the guilt, self-directed disgust, those are not changing. They continue to stay high, similar to, to what Andy had just said. So treatment interference, preconceptions, before the exposures, we need to identify core beliefs to target, avoidance behaviors, whether or not they have severe dissociation, attending sessions under the influence, or homework noncompliance, and when life-threatening behaviors reoccur, imminent risk of suicide, a suicide attempt, suicide preparation, threats, or non-suicidal preparation. These preconceptions, avoidant behaviors, and life-threatening behaviors can be serious treatment interferences, and we would need to work on them.
Yeah, and to add to that, I just want to I'm going to go back to that slide real quickly.
Yeah.
Backward. Whoops. Dissociation. The last client that I worked with, we had to unfortunately stop the protocol due to her severe dissociative episodes. And the way DBT conceptualizes dissociation is that dissociation is a cognitive avoidance strategy to cope with negative emotions. So strategy implies that patients can control their dissociative episodes. And I know that there's probably can bring up a lot of controversy, maybe within this audience, but there is controversy in the literature and the research groups around if patients can stop dissociative episodes. So the DBT approach is that through skill use and through practice, patients can begin to notice the early signs of a dissociative episode and ward it off from getting worse. So with my particular patient, we stopped the protocol and we just practiced the increasing awareness of when she started to have the early signs of dissociation.
Now, the other thing as a dissociation intervention is what I like to call the flamingo. So you cannot dissociate if you're standing on one leg. And it's very difficult. It's very difficult to dissociate when you are doing, if anyone did, wall sits, where you are, leaning up against a wall, and then you begin to sit like you're in a chair, and it's very, very hard on your quadriceps. And so again, the reason being is because if you engage your body, it's very hard to then leave the mind. Another question is, are there specific ways that you target clients being skeptical of the treatment, such as feeling unable to engage in radical acceptance, that it is just not possible for them? Yes, we definitely want to target that. We also have to do some of our own radical acceptance of the willfulness, the willingness, the willfulness of our patients, and also continuing to recognize that there's these core beliefs, these structures that people have around their trauma and their healing around their trauma have been protective for them for many, many years. And so to give that up is extremely scary. And so how to continue to work on the psychoeducation around that, and that there's purpose to that, and and to talk about what is the risk in radically accepting this? What do you see as the drawback of moving forward from that? Anything that you guys would add?
The only thing I would
go ahead.
Go ahead, Jenni. You go.
I just think I'm so grateful for these questions. Exactly what you said, Laura. I mean, my therapist would go with me down the line of, okay, well, what if you did this? What if that happened? Well, what if that happened? Like, I had a core belief that if I'm in a relationship with a man, my life will be miserable and over, and I'm essentially going to die. Everything's done. And so we would go down that trail of, well, what if we accepted this, and what if that? And that really did help me. So I appreciate you bringing that up. And I mean, one of the things that helped me most was just my therapist giving me even, research articles. And for me, that was actually helpful. Just showing this treatment really does work, to be willing to take a risk, and just holding on to hope. I mean, what you guys said earlier about hope, that can be such a barrier to treatment. And I needed all my treatment team to believe and to share hope with me that I could get better, even if they had doubts, which I'm sure happens, but I needed to see the hope, and I'm so grateful that that's what I got.
And another, oh, sorry.
No, go, Lara.
Oh, another thing that you could do to really help the client's skepticism is check the facts. So radically accepting this particular situation, this particular memory, this particular thing that had happened to that person does not mean that they're incapable of radically accepting, because what other things can they radically accept? That we do radically accept. There are certain things that we may be more capable of radically accepting, and then there's some things that are just harder to radically accept. And the other thing that I really like to differentiate for people who have a trauma history with radical acceptance is that, and to reiterate it again and again and again, is that this is not approval, this is not forgiveness, this is not allowing someone to do what they do. Instead, it is just accepting, just being willing to acknowledge that it happened.
Yeah. And I was thinking about just the idea that it's really at the end of the day, nobody is forcing them to do prolonged exposure or even DBT. And like in the second slide around the DBT stages, there's pre-treatment. Pre-treatment is so important. It's reminding them they're committing. It's their choice to commit. And that choice, sometimes we have to just go back to that, like turning the mind is another skill, turning the mind over and over and over again, just to choose to commit. I guess that's what I would add for radical acceptance.
Love it. Okay, well, hopefully that was helpful. Great question. So,
yeah.
Jenni, would you like to?
Oh, it's my favorite slide of the whole webinar.
It is your favorite slide, Jenni.
I love this slide because to me it really depicts what I shared earlier about my story and the barriers with my troubles with distress tolerance. And I mean, this is really what was happening to me. I was overengaged. I was underengaged. For the longest time, I wasn't able to stay in that effective engagement, kind of optimal activation area. And in fact, the first time I ever did my imaginal exposure that Lara explained earlier as one of the steps in PE, I actually hyperventilated and had a panic attack. And the only other time in my life I'd ever had a panic attack was actually jumping out of an airplane. So that kind of makes sense because that is life-threatening, you know, jumping out of an airplane. But actually going over my trauma memory was not. But I was just very out of effective engagement for so long. But the good news is that it took me some time, but I was able to get into that optimal activation zone and get better. And I love, Lara, what you said earlier about, you know, it might take someone 9 months of phase 1 DBT and learning skills. And looking back, I mean, now that I know what I do, I can see how that would have been really helpful for me. But anyway, needless to say, I got better, and you guys, it is an art and it's a science, and I'm grateful you guys know how to keep people in that zone, the effective engagement zone.
Well, and Jenni, just to remind you, like, you're the one. We don't keep you guys, we don't keep patients, clients in the zone. It's you do through
You're
skill
right.
use.
Thank you. You are right. And
so often,
everybody is an example of what I would needed a lot in therapy was you guys reminding me of what I had already achieved and had done, because oftentimes with PTSD, it's such a loss of self and you feel so ashamed. I'm a horrible person that we forget little things that we do. So thank you, Andy. I was able to do it myself.
Right. And, you know, just to add to that, well, Jenni, were you going to add anything else?
No, I'm good.
And I think it's helpful for clients to remember, like, we talk about target behavior use in DBT. So any behavior, any maladaptive behavior coping skill that like we talked about earlier, provides short-term relief, but in the long run just prolongs suffering. Target behaviors will take a client outside that effective engagement zone. So again, we're using our skills rather than our target behaviors to come back into the zone. And effective engagement. And, you know, I saw a definition of effective engagement that I really liked, and it's where emotional processing, so you can allow your emotions without doing anything to make them different. I guess that would be mindfulness of emotion. I think, should we move on?
Yeah, so just other ways to kind of recognize effective engagement is flow, effective affect regulation.
Sorry.
It's okay. Willingness, flexibility, challenge. They're accepting and going forward and towards challenge. and then a sense of mastery in which they are starting to see themselves increasing in intensity of, facing more intense emotions, facing more intense sensations, and finding their way through that. That is building of mastery. So we use a lot of DBT distress tolerance and emotion regulation skills throughout that. So the tip skill, where you are using more temperature-related, doing intense exercise or progressive muscle relaxation and paced breathing, checking the facts, opposite action, improve the moment skills, wise mind accept skills, and radical acceptance. Again, there's other trainings that will go over these types of skills. We're just kind of listing those for those that know DBT. So treatment interference, realistic treatment timeline is going to have interferences. You're going to be doing stage 1 skills training, you've progressed on to stage 2, and you've done a couple of sessions, and then they've reported NSSI outside of session. So you would pause the treatment and determine between the two of you and the client, how long do you need to work on the skills in order to get them back to a place of effective engagement where they can continue to increase higher levels of intensity and distress and tolerate that. And then you may be moving forward, and once again, there may have been a suicide attempt. Now, this also could not necessarily be directly related to the treatment. There could have been something happened outside of the treatment that has caused an increase in distress for that individual, such as a loss of a relationship, a loss of a support system or a job, and so forth. Something sudden or extremely disruptive for the patient's status quo, and that could have caused also more distress for the patient and caused a suicide attempt or so forth. You still would pause the treatment and really kind of assess how long do we need to have that pause for. Is it a week? Is it a month? How much information do we need to really assess that the patient is able to tolerate and find that effective engagement again? And then we proceed from where we started. We don't go back to the beginning. We go back to where we ended. We go back to where the pause started and go from there rather than going back and rewinding. That's important because we want to reinforce that it's not about starting over. It's about just the reality of this treatment, that you're going to have times where there's disruption, there's interference, and it's okay to keep going, that you can learn from them and still progress. The brain has still learned a lot. It has, just because they use behaviors does not erase the treatment that they've been given. That also is really helpful with reinforcing of the treatment. Andy, would you like to take the next one?
Sure. Therapist interfering behaviors. I can relate to this slide all so well. Prior to having training in prolonged exposure, I have to say that the fear of, I did think that it sounded a bit barbaric. How could possibly a patient with comorbidity and high-risk problems be able to tolerate the distress? So the fear of a patient worsening, and that I, as a therapist, made them worse. That was like a fear that I was fused with. Some other therapists will have a personal history of trauma, and of course, listening to retelling, it can feel like it can be a parallel trauma, and that's just something. If you have a trauma history, to get lots of support and supervision and consultation. Lack of skill. The more patients that I take on and do PE, the more confident, obviously, and competent I feel. And so lack of skill is a therapist interfering behavior. And again, just for all of us, if we are going to do prolonged exposure and exposure therapy in general, just always to be aware of judgment or concern that we might have that we've internalized. And again, the last point, rigidity around the protocol versus adapting treatment to meet more flexible, principle-driven interventions. Again, this is where the art and the science meet, and feeling the freedom and trust yourself to move away from the protocol when a client needs a certain art form to get back to the protocol.
Yeah, and I'll add, Andy,
Jenni,
thank you. That was really great. I'll add to that, something that we struggled a lot with was what I now call kind of chit-chat. So meaning like my PTSD and my marriage at the time was creating so much drama. It was kind of like a trauma tornado and just ripping apart all kinds of pieces of my life. So I would often go to treatment, and instead of doing PE, we would talk the whole time about, the car wreck I just had or whatever it was, the job I just lost. So that's a real challenge. And it's, again, back to the art form and skill, because how do you ignore that maybe someone just lost their job and, they need a livelihood, because that happened to me. But anyway, so that was just something we struggled with, was getting off topic.
Yes, definitely. I think we'll move on to the next slide.
Yeah. So troubleshooting questions to ask. Are they doing the exposure task as assigned? Is corrective information present during exposures? So are you starting to see a change in emotion? Are you starting to see change in core beliefs? That's corrective information. Are they processing the corrective information? Are they able to talk about the emotional changes? Are you starting to see, sensations and intensities change and so forth? Are they able to discuss that with you, even name it themselves? So even when they're doing their homework and they're listening to the retellings, that is a huge part of that reprocessing, is that they're taking in the information as though they're listening to the story rather than telling the story, and they actually have a lot of internal corrections happening, and sometimes even without them, out processing it out loud. And so can they recognize that, and can you talk about it? Are they willing to let go of problematic beliefs? Do they believe the corrective information? Do they believe that this reduction in anger, this increase in radical acceptance is believable, and that they recognize it and take it in? And is learning generalizing to all relevant contexts? Are you starting to then see those in vivo exposures also helping them change as well? So they're able to go to more social events. They're able to do a job interview. They're able to take risks in other ways where they didn't before. Increase joy in one's life. So signs that DBT-PE is working, their problematic beliefs are changing, the unjustified emotions are decreasing, and PTSD is improving. Their self-reports, their rates of PTSD are going down. Just a case example of a patient who went through DBT-PE. She was 19 years old, single female. She had PTSD, generalized anxiety disorder, history of substance abuse, pervasive depression, sexual and physical trauma, impulsive behavior, drinking, sexual activity, and also tattoos, present dissociation in sessions and throughout the week, difficulty asserting her needs, and becomes hopeless and helpless. So what we started to recognize is with the over-engagement, so that dissociation, the inability to tolerate higher levels of intensity, so being out in crowds, being around others, we actually had her do an exposure around walking. We were in Chicago, walking on Michigan Avenue without safety tools for 10 minutes during high traffic. She would have these safety tools that she bought online that there were hard plastic that had jagged edges that she could use as self-protective tools to support when she felt that she was in a high-risk situation. Well, in broad daylight, it was the low probability of anything negative happening to her. So having her walk without them and leaving them behind.
Sorry.
It's okay. And then to help her with the under-engagement, we actually did some behavioral activation of having her assert her needs about getting the medication ordered from her psychiatrist in a timely fashion, even when shame and self-blame came up. So really having her practice things that helped with over-engagement and under-engagement to help her find more effective engagement through this process.
You ladies
Jenni,
have
do you
anything
want to
you
share
want
your
to say?
conclusion?
Yeah, well, I'll share mine, and then I'll let you guys give some concluding remarks too. So if you guys notice on the slides, there was a little bamboo symbol on some of the slides, and that happened to time up with when I was speaking. You might have noticed that. And why did we choose a bamboo symbol? Well, we have an inspiring story. We're actually going to send you this article as well, so you might want to share it with your patients. But bamboo is actually quite inspiring, and here's the story. So if you plant Chinese bamboo, the first year you might water it and nurture it, and nothing happens. The second year, water, fertilize, you go out there, you look at the soil, and there's nothing there. You do this again the third year. Again, you're watering, you're fertilizing the soil, and you're going out there and you look at the yard and there's nothing there. This happens through the fifth year. So finally, sometime in the fifth year, Chinese bamboo shoots up about 80 feet in about 6 weeks or so. So obviously the moral of that story is it really wasn't that nothing was happening during 5 years. What was happening during those years was building a foundation. A bamboo could not shoot up that fast and that high if there was nothing happening for 5 years. Of course, underground, it was building a large foundation for that amount of growth to happen. And how does this relate to our presentation? Well, this might be many of your patient stories, and it was definitely my story. For so long, even in PE treatment, which ended up really helping me, I didn't feel like anything was happening. Now looking back, of course, I can see that all that time I was learning, I was growing, I was getting a foundation, and I loved what Lara, you said earlier about not starting over, but you're just going back to where you started or where you ended off, right? So that was a key in my recovery too. And so I went from hyperventilating the first time I did my exposure as far as imaginal to now I'm doing, I've done 3 webinars like this, and who would have thought I would have ever done that, because I was hyperventilating sharing this story. So that just shows you an example of even an exposure. This might be considered an exposure for me, and we've calculated. We've done this 7 times now, so there you go. But I love what we mentioned earlier. Phase 3, building a life worth living. I feel like that is where I am now, and I feel like that never ends, and it's exciting, and it's fun, and it's awesome. And PTSD recovery does happen. The trauma never goes away, but I learned that a memory does not have to scare me, and a memory that kept me paralyzed for about 12 years of my life, it doesn't have that power anymore. Facing the memory released me. It was the captured memory, like we mentioned earlier, that kept me stuck. And so I'm just grateful that this treatment exists, and I'm grateful to do this with you ladies and that all of you guys participated. We do have some time for questions. As you guys are thinking of questions, Lara and Andy, do you have anything you want to end with in conclusion?
I mean, I really hope that those who got to be a part of this got to also experience what I did when I came across this as just an opportunity for our patients, an opportunity for us as clinicians, those who I feel like have the courage to venture into trauma treatment and really continue to learn and build skills to really help those that need our assistance. This was wonderful for me. To me, I just felt like I feel really equipped going into trauma treatment with this protocol. I feel as though it's given me an opportunity to really help those that others may need support in helping helping them find a healing path. So I hope that others have found this to be as eye-opening and enlightening as I did.
Yeah, and something to add is I've gone with Lara and Jenni and presented at different conferences, and there are different camps so to speak, in the trauma world. There seems to be the evidence-based people and more of the, Bessel van der Kolk's people. And where I just see there's room for everyone. And even DBT, like Melanie Harned chose PE to integrate within DBT, but to be honest, you could, if you're an EMDR provider, you can integrate EMDR within the DBT stages of change. And we at our center use a lot of work from Bessel van der Kolk and the somatic experiencing curriculum as well. So just to say that there's room for it all, and obviously patients are unique, and treatment needs to be tailored to the individual.
Yeah, that's a great point. And yeah, I think just to close off, Andy, it's such a great point. And this was a PE-specific talk, but in my recovery, I actually did ACT. Of course, we talked about DBT, but I also did somatic experiencing, a lot of the work of Dr. Bessel van der Kolk, and acupuncture and massage and EMDR was really helpful too. So it was a big puzzle, and we had to put it together. So are there any questions? We have about 5 minutes. We can answer questions. I think, let's see.
Do we have any?
Let's see, there's one. Oh, okay. How do you help manage dissociation in a session? I'm going to let you guys take that one.
When I touched on this, when we talked a bit about having a patient recognize the early signs and of when they're about to dissociate. So for many clients, it's, I had a client, she started to feel tingling in her fingertips. So we would just practice and practice and practice, sitting with her, like doing a body scan and getting very familiar with that first sensation, and then experiencing and just sitting with that and seeing where that sensation goes in her body. And then, of course, using skills like the tip skills, changing her body temperature, standing up. I would say, okay, it's time now. We're going to get up and walk. When she start to go into a more dissociative phase, I would say, let's get up and go for a walk. If she couldn't go for a walk, it's like, let's put 2 feet on the ground. Like Lara said, doing being a flamingo. And we don't want to shame clients for dissociating, and it's a delicate balance. We also don't want to treat them as fragile and feel that they can't gain mastery over their dissociation. So that's where, again, I've found the DBT viewpoint of that clients can control their dissociation to be very powerful for the client.
That was really great. I wish I would have known the flamingo back then. Does someone want to talk about the next question? As we have a few more minutes. How would you modify the DBT-PE protocol for eating disorder patients?
We actually, just to interrupt, because I would like to prioritize questions that come in. We got a question of any suggestions for patients who cannot tolerate body scanning and or engaging the body due to BDD. Anybody would like to?
Can they tolerate it? Yeah, can they tolerate? I'm just curious if they could tolerate it for like 30 seconds. Or I guess I would also help them, work on physical grounding outside of, like, do more touch and sight and smell rather than focusing on internal sensations. I don't know if, Lara, you would have anything to add to that. Or it could be an audience answering that for us. We could see the answer.
Yeah, I would agree, Andy, what you had said, which is with dissociation, you actually don't, it depends on how you want to treat it. From a behavioral standpoint, you don't need to have them work on the sensation of dissociation, but instead to actually recognize that it's used as a coping mechanism, and that it is being triggered because there is an emotion that's happening that they are wanting to repress, they're wanting to numb out from, they're wanting to remove themselves from. So instead it's about how to stay present. So that's where the flamingo, or having them do a wall sit, or having them stand on, just even stand up and like moving their, kind of like bouncing in their legs and their knees, and continuing to talk to you about whatever it is that they're feeling in that moment, like when they're about to catching the dissociation, working with the dissociation. You can do it that way as well, so they're not necessarily focusing on the body sensation of dissociation, if that.
Yeah,
okay,
I think,
so the patient cannot handle physical sensation at the moment. Sorry for any confusion.
No worries. Yeah, I think for that. Go ahead, Lara.
The secondary approach may be an opportunity to work on it from a different standpoint.
And maybe
so
just to focus.
Time. Sorry.
Yeah, I see.
Just due to time, I just wanted to say thank you. Please remember to stay logged on after the presentation ends to take your survey and provide feedback. For those of you who wish to receive CE credits and who answer the CE questions, you should receive your CE certificate within 14 days.
And thank you
really
so much. We'll be sending you guys this PDF PowerPoint so you have it. And thanks for all the work that you do. It's really important. We appreciate you joining us. Thanks to Alia at Eating Recovery Center for making this happen.
Yeah, thank you, Alia.
Thank you.
Thank you all. Good night.